Hi, my name is Dr. April Armstrong. I'm Professor of Dermatology and Associate Dean at the Keck School of Medicine at USC. In our session, Clinical Pearls for the Management of Psoriasis, we talked about a number of different things. First of all, when we think about patients who are about to be pregnant or are pregnant with moderate to severe psoriasis, we looked at biologic options and then recommendations. Sertolizumab, which is a TNF inhibitor that does not cross the placenta, is typically recommended in those cases. And narrowband UVB is also another option. And then finally, for people undergoing surgery, for example, and they're wondering whether they should stop their biologic, well, for low-risk surgeries, and those are surgeries where the respiratory tract, GI tract, and then GU tract are not penetrated and are essentially conducted under sterile conditions. So essentially our orthopedic surgeries, ocular surgeries, as well as derm surgeries. In those cases, we do not need to stop the biologic. For the other cases, it's important to discuss with a surgeon on a case-by-case basis. If necessary, then the biologic could be stopped for about 3 to 4 half times before the surgical date and then restarted about 2 weeks after. And I would just want to say Dr. Richard Langley really presented a great case of TB and talking about how the TB rates are important to consider worldwide and how the IL-17 and IL-23 inhibitors should be especially considered where patients are traveling to those areas that are endemic with TB. And then finally, I would say Dr. Pariser really highlighted the point that the true treatment target goal is where you ask the patient, what would you do if you did not have psoriasis?
Great, and I'm Joseph Merola. I'm a dermatologist and rheumatologist from Boston at the Brigham and Women's Hospital, Harvard Medical School. I enjoyed the session very much. I'd say I'll cover the last two topics that were discussed. We talked a little bit about how the patient with active malignancy really is excluded from clinical trials and a lot of our registries often. And so there's really an unmet need in terms of our ability to treat patients appropriately, I'd say, with active malignancy. We talked a little bit about the data for biologics, including anti-TNFs, how there may be a little bit of over-concern based at least on some of the registry data to date. That's mostly data from rheumatoid arthritis and other disease areas. However, I think there's still some lingering concerns in that space. In particular, we focused on some newer largely preclinical information about IL-17, the IL-17 axis, and its role in malignancy. And then took a look at some both preclinical and clinical data that suggest that IL-17 inhibition may actually be compatible with malignancy in at least two particular specific malignancy types. It turns out it may even be beneficial. So I think there's a lot more to learn there. Could potentially be an option for our patients with active malignancy. And then finally, I would say we heard from Dr. Alice Gottlieb, who talked about pediatric psoriasis, some new, very exciting and incredibly important data for pediatrics and adolescents. And she presented IL-17A data, I believe ixekizumab, among others, who are starting to really think about our pediatric patients, which is incredibly important. So that summed up our session.